All right, students, welcome back to our next installment of the skeleton. Now, we've been talking about the axial skeleton previously. The last video covered the appendicular skeleton, focused on the upper body. Now we're going to go and slide on down to the lower body. And we have to go back to a couple bones that we looked at before, primarily the sacrum. So this is the most, I guess you say distal, furthest away from the center, the tailbone, right? Now, the important thing that we need to know about is that sacroiliac articular surface, which we spoke about when we were covering the axial skeleton, right? Axial skeleton would be comprised of the skull, the vertebra, as well as the sacrum. But the pelvic bone itself will be part of what we are going to call the appendicular skeleton, specifically of the lower body. Now, I have two pelvises sitting here, right? And yes, we can definitely take a disarticulated version of one pelvic bone alone. So if I go ahead and line that up just so, you can see exactly how this is a left pelvic bone just by itself. And if we look at that surface that we had seen before with the sacrum, that's going to be our first landmark. So if we pull those apart, we can go ahead and take that first bone, the ilium, out, and we can see the whole thing as one structure. Now, a pelvic bone is made up of three key bones. And if you follow your checklist, number one is ilium. Ilium, essentially speaking, is the portion in which I'm holding in my hand here, the upper half of the bone. If I move downward, we have a more posterior portion, which is covering with my hand right now, and that's called the ischium. And if we move to the most anterior portion, which my hand is covering right here, this primary portion is strictly called the pubis. Now let's go back up to the ilium where I was talking about that sacroiliac articular surface. So if we move to the medial and posterior portion of the bone up here where my thumb is, we can see this flat yet grooved surface. And this entire surface here, the most superior, posterior, and medially located portion, this is that sacroiliac articular surface. So it creates the sacroiliac joint with the sacrum right there. So a joint, yes, it is still a highly movable joint that we have going on here, even though it may not seem like it moves very much. There is some sway to the hips, so to speak. Now we move to the more anterior portion of this bone, okay? So I'm just gonna start with the actual pelvis in general here, just to see the ilium. If I go and stick my thumb in this cavity here, okay, this is known as the acetabulum. The acetabulum is the position in which the head of the femur is going to sit to create an actual joint movement so we can cause locomotion and we can actually walk, right? Now, what we notice about this acetabulum is that it's a huge socket, right? Really big. When we compare that to the glenoid cavity of the scapula, that was seen very flat, like you almost stick your thumb in the depression only. So it makes the shoulder much more highly movable compared to the hip joint itself, where this acetabulum sits. But it also makes it a much more sturdy structure at the same time. Moving on to letter C on your checklist, and D, these are the anterior, superior, and anterior, inferior iliac spines. And we have it abbreviated ASIS, but for our purposes, we're gonna want you on the exam to say anterior superior iliac spine and anterior inferior iliac spine. And we'll find these, of course, bilateral, but just to point these out, if we can find this crest right here, and we move most anteriorly to the first point that sticks out, this is where we're going to be finding the anterior superior iliac spine. Now, if I take my probe and I just slide on down and I go to the next bump or protrudence that I see here, we have actually found the anterior inferior iliac spine. So they're always going to be lining up together. Anterior superior iliac spine, anterior inferior iliac spine. To see the next two structures, we're going to go ahead and take our pelvis and flip it around. All right. So again, from the ilium is our upper half of the bone. The ilium, if we follow this crest again and move to these two large points, we have one point which is posterior. We have a secondary point which is also posterior here. Okay. So if we go through these one by one, we have the posterior superior iliac spine and the posterior inferior iliac spine. And the larger protrudence right here, that's going to be the superior, sorry, let me say that again. This upper one is going to be the posterior superior iliac spine. And if we just simply slide down a little farther, the next notch that we see sticking out is the posterior inferior iliac spine. I'm going to give you a quarter turn so we can see a side view, a lateral view. And now with this lateral view, okay, now we can go ahead and see those 2 points a little bit better. Again, the superior posterior iliac spine and then the posterior inferior iliac spine. All of a sudden, we see a curvature where we can stick our finger in very easily. I'm sure you've heard of sciatica, or sciatic, right? Sciatic nerve pain. The sciatic nerve is going to run right through this portion right here, and that's why it's going to have this name. It's known as the greater sciatic notch of the ilium, to be very specific, because again, the upper half of the entire pelvic bone is the ilium. So if we find the greater sciatic notch, that is still part of the ilium. The last structure on your checklist is the crest I was talking to you about to find some of your landmarks. And right here is the iliac crest, where you put your hands on your hips. The iliac crest. Moving forward to the ischium, again, as I said before, that is going to be the lower posterior portion of the bone. Essentially all of this portion all through here. So give me a second, I'm going to flip it around a little bit more, see if we can get to balance. Excellent. All right, so if we move below the acetabulum, okay, now we've officially landed into the ischium. Now the ischium has 4 specific points that we want you to know about. Let's go ahead and start at that greater sciatic notch of the ilium, and this will help you see exactly what we're talking about. I'm going to follow that down, and then I'm going to see a point, a very sharp point. Okay. Now we've officially reached the ischium. And this first point of the ischium is called the ischial spine. Okay. Ischial spine, another very sharp protrudence. And then we see another little notch, right where my finger falls into. We had a greater sciatic notch with the ilium. This little notch right here is going to be called the lesser notch. And instead of the ilium, it's going to be the lesser notch of the ischium. So we have ilium before, now we have ischium. Let me go ahead and stick my pointer in here. We're going to find the ischial spine. And when we move down from the ischial spine, we reach the lesser sciatic notch of the ischium. Zooming out a little bit and focusing. Okay. The next item up for bids is going to be the obturator foramen. Well, one foramen. Foraмен's a hole, right? We found that before with the skull many a times. Here is the only hole I can see on the entire bone. So obturator foramen, one of the largest holes we will ever see through a bone. The last structure is the ischial tuberosity. This is where you say, I got a bony butt. So I'm going to slide over to this one since it's sticking out perfectly for us. And if we move just below the acetabulum, just inferior, we will see this large lump, right? And again, this is going to serve as an attachment site for some more muscles. And we'll get to those muscles next unit when we want to cover those. But for now, we just want to know those bony landmarks. So the most inferior bony protuberance in general right here, right, is the ischial tuberosity. You got a bony butt? Yes, you do. So we can see ischial tuberosity. We can see that lesser sciatic notch of the ischium. We can see that ischial spine. They all line up ever so nicely along that most lateral moving posterior portion. The last portion, as we touched on briefly, is going to be the pubis. Okay, the pubis is that anterior inferior portion, about a quarter of the bone altogether of the pubic bone. Now the pubis, okay, there's only one portion we want you to know about, and that's going to be the symphysis. Specifically, this is going to be called symphysis pubis or pubic symphysis. It's up to you, don't matter to me. But essentially, it's just the point in which the two pubises align together. Pubi? I don't know. I'll let you figure that one out on your own. All right, so now moving forward, we've learned and identified the terms of the pelvic girdle, the pubic bone, with the pubis being the most anterior portion. We had the ischium and the ilium of the entire pubic bone. Okay. Now we want to be able to identify a male versus a female, right? These are structures we're born with, these are, you could say, almost hard to change, right? And this is how we can identify straightforward, okay, 4 key elements. 4 key elements to tell you, do we have a male articulated pelvis or a female articulated pelvis? These are the key notes, okay? Number 1 note for me, though, even before those 4, is can a baby's head fit through this cavity, right? That's the key thing here. How big of a surface do we need, or an area, I guess you could say, for the head of a baby to fit through during childbirth? Now, for purposes for education here, I have a plastic fetal skull. Now, a plastic fetal skull is right about the size of a softball, you could say, or a grapefruit. So we got to think, can this skull, the largest part of a baby, fit through the pelvis? If so, that is more than likely going to be a female. But we want to go through 4 criteria to understand that this can fit through or not. Okay. So number 1, or I should say letter A on your checklist. Letter A on your checklist is width of the pelvic inlet and outlet. Okay, so width of pelvic inlet outlet. Simply enough, we're going to go ahead and sit up above, and we can look down. Okay, when we look straight down into this pelvis, right, we have to imagine inlet is going in, outlet is coming out from the bottom. Same thing with this one. Inlet is going in, exit is coming out the bottom. So I'm going to take this fetal skull. Okay, criteria number 1. Female, simply enough, they're going to have more space, more area to fit a baby's head through. So if I drop this in there, look at that, stuck. Never going to make it through. Got to be a male's pelvis. Checking the other one, I go ahead and take that. Does it fall through? Look at that, perfect. Doesn't even touch at all. What first criteria? Width of pelvic inlet and outlet. So simply enough, very large pelvic inlet and outlet for a female. Criteria number 1 checked off. Now we can't always go by just one. We want to make sure we have at least 3 of those checked off to guarantee we're correct. Okay? That's why we have letter B, C, and D. So letter B says degree of sacral curvature. Okay? Simply enough, look at the tailbone. Look straight down, okay? With a male, all right, what points forward? We're going to see the coccyx. It's pointing anteriorly. If I take it and I pick it up and I give you a side view, lateral view, right? Look how far forward that projects, towards that pelvic inlet and outlet. No wonder, right? A man can't have a baby. It's blocking. There's no way a baby's head is going to fit through there. The coccyx is pointing way too far anteriorly. Never going to happen. More than likely, this is a male pelvis. Switching over to the female pelvis, we look in and right, we look at the coccyx, very minimal, and also with the sacrum, it points straight downward versus pointing anteriorly. Again, giving you plenty of ample space to fit a baby through. The third criteria, letter C, is the width of pubic arch. Now, if we look at the pubic bones, how they come together here at the pubic symphysis, what we're seeing is that with a male's pelvis, it is always, generally speaking, less than 90 degrees, meaning this angle right here that we see is less than 90 degrees. In this case, this looks to be like a 45 to 60 degree angle, not very wide. But if we move over to this female pelvis, right, now we can definitely see a humongous difference here. The key with a female's pelvis is that width of pubic arch is going to be greater than 90 degrees. In fact, if I take my hand and I try to create an angle, it looks like it's about 120 degrees or so. And again, during childbirth processes, the pubic symphysis does weaken a little bit on purpose to allow this to spread a little bit more and create a greater angle to ensure that the baby's head and entire torso, right, is going to fit through, not effortlessly, right, but easier. The final criteria is going to be letter D, the degree of lateral projections of the ilium bones. So simply enough, I like to really say ischial bones. If we look at that ischial spine, we're looking straight down into the male's pelvic cavity here, and we're looking here, right there. We found the ischial spine. Now what you notice with a male's ischial spine is they point much more medially overall. And again, if I take that fetal skull, again, it's going to hit those 2 points, making it impossible to give childbirth. Versus if we move to a female's pelvis, now we can see those ischial spines. They don't project as medially. So now that baby's skull, even if it's sideways, fits through perfectly fine. No issues at all. So again, skull is key. It helps you figure that out a little bit more. A man's never gonna fit through. A female's 100%. It's gonna make it. That's why a woman is made to have childbirth. So you can always tell. Look at the bones. To show the entire skeleton as one whole unit, I'm gonna go ahead and jump at this pelvic bone right here. So we'd already identified all the structures with the ilium, the ischium, and the pubis, the more anterior portion, okay? Now we wanna move into the long bones, we could say, of the entire lower limb. Now with the limb, the leg I should say, we have the first long bone being the femur. We move down to the knee, and we can see a little patella here. That's the only thing we're gonna ask you about. Name this bone, patella. Heart-shaped, I guess you could say. Nothing else you need to know that's significant about the patella, just name it patella. But that's our kneecap. We're not gonna accept kneecap on the exam, of course. But then if we look down where the femur meets the knee, now we actually have the tibia. And if we follow the tibia is the more medially located bone. It's the weight-bearing bone of the leg. And then sitting just lateral, we have the fibula, the non-weight-bearing bone, but still very significant for certain muscle attachments and moving our ankle. If we move a little bit farther, we can see the ankle joint, and we have the entire foot, which we'll get to here shortly. If we move over to the bone that I have here on the table, okay, what I have lying on the table is specifically a left femur, but we're not going to ask you left or right on the exam. We're just going to ask you the certain specific points. Now, the key thing I want you to see first is the most proximal portion of this bone. Remember, proximal is close to the midline. Distal is closer to, or I guess you say furthest away from the center. So distal, away, proximal, towards the center of the body. The first proximal portion that we need to know about this femur is going to be the head. And that's going to be this ball-looking structure that's found most medial and proximal. And with the head of this femur, we're also going to be able to wrap our fingers around and call this the neck of the femur. So yes, that's one bone. It has the head as well as the neck, in which my hands are holding on right now. I skipped a structure, fovea capitis. Now, if we move to the most medial portion of the head of the femur, we're going to find a depression. These bones are a little calcified, right? They're starting to break down because they are real bones, but we do see this one large depression, fovea capitis, the only depression you're going to find on the head of the femur. Number 4 on your checklist, if we move from an anterior view of this bone, we're going to see one large structure sitting just lateral to the head. And this is called the greater trochanter. Again, it's going to serve as attachment sites for some muscles like the gluteal muscles, but we'll get to those later. The key thing that I want you to know here is that it's going to be the largest protuberance, right, lateral to the head, the greater trochanter. Technically speaking, this is the most lateral portion of the human body. So when you're walking along or you hit something and you go, oh, I just whacked my hip. Well, maybe not. You might have hit your femur. Look here. What sits lateral? Well, their leg's kind of whopper-jawed, I guess you could say. But if we were to take this bone and stick it in place, we can see how the greater trochanter can stick out even wider than the iliac crest of the hip bone. Now we had a greater trochanter. Let's find the lesser trochanter. Simply enough, we're going to go ahead and take the bone and we're going to spin it around. We had the greater trochanter located most laterally, but we're going to notice that on the posterior and medial surface, so just below the head's medial, we're going to find the lesser trochanter right here. Good. Now we're going to skip this one here. If you see this sharp ridge coming down from the greater trochanter along the posterior portion of the bone, this is going to be called the gluteal tuberosity. Again, another attachment site for some of those gluteal muscles to insert. But we're going to follow that down, and another one on your checklist we're going to skip on you, number 9. And this is called linea aspera. It's the sharp ridge that we see along the midline of the bone on the posterior surface. So, I mean, just for your purpose to know, greater trochanter, that's a key one for the test. We follow down, gluteal tuberosity. Again, we're going to omit that from the test, but just so you know. And then if we follow that down, again, omit from the test, linea aspera, that most posterior ridge along the back or posterior side of the femur. Now, if we move down to the most distal portion of the femur, we need to know these structures. These are the lateral condyles and medial condyles. So on this bone, to be specific, right, we can find the head of the femur. That's most medial. So medial means that the medial condyle is going to be this articular surface. A condyle is an articular surface. So if we look a little closer, there we go, the smooth surface of the knee, in which it creates the knee joint. We have the medial condyle, and if we simply move lateral, we in turn have the lateral condyle. The last structure that we need to know is going to be the intercondylar fossa. In that case, we're going to take the bone and we're going to flip it over to the posterior portion. And if we can find that linea aspera, we move down and we can stick our finger right in between the two condyles. Intercondylar fossa, the depression that we see on the posterior distal surface of the bone. Again, patella. All we need to know about patella is that we have a patella sitting here as our kneecap. That's all you need to know is patella there. Tibia, though, we're going to ask you a lot about that. You take my femur, I'm going to put it back. I'm going to take my tibia. Oh, nice brand new tibia, looking beautiful. All right. Now again, we're not going to ask you left or right, but if I were to take this bone and I were to put it in my leg, it's the more medial bone of my right leg. Okay, so we can see the medial ankle, we can see the medial portion of the knee. I'm going to take this bone and sit it upright so it looks as if I'm standing in front of you. My right leg, right in front of you. Stick with the checklist here, okay? First item on the checklist was the medial condyle. So yes, we have medial and lateral condyles on the femur. Those are found distally. We have medial and lateral condyles found on the tibia, but these are located more proximally. So they're going to actually work together, you could say, the femur and the tibia, the condyles. So as I orientated you, and I told you this was a right bone, but not that I'm asking you specifically. So I'm going to follow this point that I know. And what we see here is the medial condyle of the tibia. And then coinciding, we move to the lateral condyle of the tibia. Next item on your checklist is the medial malleolus. And that was that structure that I looked to at the most distal end of the bone. So we're going to see one large styloid process, almost looks like, right? It looks like a gigantic styloid process of the radius. But in this case, with the tibia, this is creating our inner ankle, hence being called the medial malleolus. Okay, the medial malleolus, the most distal and medially located structure of the tibia. The fourth item is the tibial tuberosity. The tibial tuberosity is located just superior to your shin. So go ahead and feel on yourself, on your shin, right? Move below your kneecap, and you're gonna feel this large protuberance right here. This is the insertion point for the patellar tendon. The patellar tendon is gonna run from the patella to this tibial tuberosity to allow for the quadricep muscles to insert. That would even create knee extension. But tibial tuberosity. If we follow the tibial tuberosity downward, we come to the sharp edge of your shin. And the sharp edge of the shin hurts like the dickens when you get kicked on it, right? Doesn't it? Yep, it does. But this, simply enough, is called the anterior crest of the tibia. The sharp edge, the anterior shin, anterior crest. Hello. Fibula, we're going to keep it easy for you here. Fibula, real easy, okay? Simply enough, name this bone. Fibula. But I need you to know 2 points on it, okay, for the exam. And I'm going to make this really straightforward for you. Look at the distal end of the bone. Looks kind of like a snake head, doesn't it? Pointed. Nothing necessarily flat or perfectly smooth. We move to the proximal end of this bone, and we notice that the head of the fibula is very flat. I turn that for you. You can see how flat that surface is because this is actually creating a joint with the tibia. So a very flat superior surface. And again, we move to the most distal end, and that's going to be called the lateral malleolus. So we had a medial malleolus with the tibia. With the fibula, we have the lateral malleolus. Looks like a snake. So what I always like to do is grab it by the head and hold it as if I'm Lord Voldemort and say, "You are a fool, Harry Potter, and you will lose." And what's he pointing away at? The snake, Slytherin. The snake is the lateral malleolus. All right, happy days. We have moved down to Roman numeral number 7, the foot and the ankle. For our purposes, we're always going to have the entire foot and ankle together as one unit. All right, we're always going to give you that because it would be very difficult oftentimes to separate these bones on the exam right now the way it's set up. But we're going to show you some of these disarticulated after we cover them all superficially first. Now, the first structure that you see on your checklist are the tarsal bones. And we're going to go through those one by one. Number 1 is the talus. What I like to say is that the tibia sits on top of the talus. The talus is creating our true ankle joint. So the talus is the most superior and proximally located bone. I can hold the talus all by itself. Now, if we look at the heel bone, okay, we can't say heel bone on the exam, but for our purpose, we're going to call this the calcaneus. I like to say I callus up my calcaneus because, right, you walk on your heels, you get callus on the bottom of your foot, callus up the calcaneus. So the calcaneus is our heel bone, the most inferior and posterior located bone of the entire foot and ankle. Now what I'm going to do is place this foot flat. So we have a left foot, okay, pretty straightforward. Left foot like it's standing on the table. Let's move down to what are known as the cuneiform bones on your checklist. And to see those, we're going to move from the talus here, and we're going to shoot distally. And we're going to see 1, 2, and 3 bones all lining up in a row before we hit the metatarsals. Now we do have one bone that's just before there, right? If we see the talus, we move distally, and we see this bone here. This is very important because this is called the navicular bone. The navicular bone is going to navigate the 3 cuneiform bones that we see here. And we're going to name them based off of their placement within the foot. Okay. So if we go with those one by one, number 1, cuneiform bone. Number 1, we can call it cuneiform 1, or to keep it even simpler, medial cuneiform, the most medial found cuneiform bone. Again, this is the great toe, your toe. So medial cuneiform. Here is the middle or cuneiform bone number 2. Middle, because it's located between the 2 other cuneiform bones. If we move from the middle cuneiform bone outward, we can find the lateral cuneiform bone, or cuneiform bone number 3. We can call it that too. But again, just for orientation purposes, it's easy. Lateral cuneiform. The final one on your checklist, number 4, is called the cuboid. And what we're going to see is the calcaneus. And we follow the calcaneus on the lateral portion. It's going to create a joint with one bone right here. And this bone right here is called the cuboid bone. Cuboid, kind of cube-shaped per se. Now on the hand, we had metacarpals. Now we have metatarsals with the foot. So think tarsals, toes. That might make things more, easy for you to remember per se. But simply enough, right, the arch of our foot is what's creating those metatarsals. And we name them or number them the same exact way as we do with the hand. So we have metatarsal number 1, metatarsal number 2, metatarsal 3, metatarsal 4, and to be a little redundant, but hey, metatarsal 5. Now we move to the phalanx, or phalanges, I should say in general, for all of them together. And we're going to count them the same way we did with the hand, all right? The thumb and the great toe are both number 1. The pinky and the pinky toe are both number 5. And we're going to see the same number of phalanxes altogether, or phalanges, as we would with the hand. So let's go ahead and start with that. Let's start with the proximal row first. We move from the metatarsals distally, and we have phalanx number 1. Well, with phalanx number 1, this is the proximal phalanx number 1. We need to be very specific. Proximal phalanx number 1, proximal phalanx number 2, proximal phalanx number 3, proximal phalanx 4, and proximal phalanx 5. Let's move on out to the most distal row now. We can see distal phalanx number 1 here, distal phalanx number 2, that little one there, distal phalanx 3, even smaller, distal phalanx number 4, even smaller, and distal phalanx number 5. Boom, 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 all in a row. And this is where things get weird again, right? Middle phalanx. There is no middle phalanx number 1. Does not exist, right? Because just like our thumb, the great toe only has 2 phalanges. So we skip over to middle phalanx number 2, middle phalanx number 3, middle phalanx number 4, and last but not least, middle phalanx number 5. Very small bones. So make sure you always find those. Start proximal, start distal, find in between with each. Easiest way to get where you need to go. The last item up for bids on your checklist is a seismoid bone. And we can only show you this one way in the lab right now. Now, if we were to have an x-ray of a hand, you could see this on your APR. You can go ahead and find that under the x-ray section and look for seismoid bones. But for your purposes, just to know, there is a free-floating, well, not necessarily free-floating, but a floating bone that is found in the thumb at the beginning of the first metacarpal. Well, we'll find or should I say the distal end, but at the distal end of the first metatarsal, we will see these 2 little protrudences on the plastic bones. So these won't exist on the real feet that we have here in lab, but we do have these 2 little nubby bones here. These are called seismoid bones. They are separate bones from the rest of the foot, serving as attachment sites for some of the muscles that we have. If we look at the real bone, we flip it over, those 2 bones have been omitted. So this would be the placement of where we would find those seismoid bones.